Good morning. I'm Susan. I'm going to be your nurse today, Mr. Bushinski. I'm here to do a health assessment on you, and the first thing I would do, once I come in the room, I would provide for patient privacy. I would wash my hands and perform hand hygiene. And then the next thing I would do is I would do a general observation of my patient on the exam table. So I have a 64-year-old, well-developed, well-nourished male patient who is in no apparent acute distress. He's dressed appropriately, aside from the fact that his t-shirt is often shirt for the climate and the time of year that we're in. And so the next thing I want to do is I want to assess Mr. Bushinski's orientation. So I'm going to say, can you please state your name?
David Bushinski.
Can you state your date of birth?
6/3/55.
Can you tell me where we're at?
Eastern Michigan, in an exam room.
And can you tell me why you're here today?
To have a physical.
Can you tell me who the President of the United States is?
Donald Trump.
Can you tell me what year it is?
2020.
Okay, great. So he's alert, awake, orientated ×4, person, place, and time and situation. So the next thing I want to do is I want to evaluate his speech, and I've already done that because in talking to him, his speech is clear, it's coherent, he's not slurring his words, and so he's able to articulate without problems. The next thing I want to do is test for muscle strength. So what I'm going to have him do is I'm going to ask him to remove his glasses, and I'm going to have him go ahead and push his cheek up against my hand with resistance, and the other cheek, push his forehead downwards, push the chin downwards, and push the back of the head against my hand against resistance, and then shoulder shrug. Shrug your shoulders against resistance. So his muscle strength is intact, it's bilateral, it's symmetrical, and he has no deviations or weaknesses. The next thing that I'm going to do is I'm going to ask him to squeeze both of my fingers with his fingers, and they are strong grips bilaterally. Okay, let go. And the next thing I'm going to do is I'm going to have him push against my hands like the gas pedal, and then push up against my hands, okay, and then push out against my hands and push back against my hands. And then I would have him push up against my hands and push downwards against my hands. So his muscle strength is intact in both his upper and lower extremities. And it's a 3 out of 5 on a scale of 1 to 5. The next thing I want to do is I want to check his dermatomes. There's pictures in your textbook of the dermatomes, and we're going to do 2 areas on each arm and 2 areas on each leg. And what you would do with your patient is you would give them a test, and you would say, I'm going to test your sensation. I'm going to do this by using a cotton ball, and this would be soft, and I'm going to use this as sharp with the tongue depressor or a key or whatever you have available, and that's sharp. And when I have you close your eyes and I either touch you with the cotton ball or I touch you with the tongue depressor, tell me if you feel soft or you feel sharp, and tell me what body location, like right upper arm or left lower leg, that I'm touching, okay? So normally the patient would have shorts on so that you can get better sensation testing for the lower extremities, but we're going to pretend today and we're going to do the testing with his jeans, or he's going to lift his jean up in order to do that. So can you please go ahead and close your eyes for me? Can you tell me what you feel?
Sharp.
And where do you feel it?
Upper right arm.
Can you tell me what you feel?
Soft.
Where do you feel it?
Lower left arm.
What do you feel?
Sharp.
Where?
The lower right arm.
And what do you feel?
Soft. Upper left arm.
Okay, and then we're going to do the same down below.
Sharp. Upper middle of the leg. Left leg.
Okay, and what do you feel?
Soft. Middle of the right leg.
And what do you feel?
Soft. Upper thigh.
And what do you feel?
Sharp. Upper left thigh.
Very good. So basically his sensation is intact and there's no abnormalities. So the next thing I want to do is I want to test his deep tendon reflexes. So the important thing when you do this on your patient is not so much that you elicit a jerk or a response, but that, and I'm going to have him remove his shoes at this point. And on your patient, you probably want to have them remove their socks so that you can do your Bushinski. So the important thing is not so much that you get a response, that you show me on your video that you're hitting in the right area. So on the upper arms to do the triceps, the first thing you're gonna do is go in this area right above the elbow. There's like a little groove, and you're going to basically hit that, and you should have a jerk of the lower arm. And the trick is getting your patient real loose so that you get a good response like that one. And then the next thing is you're going to do the biceps tendon, deep tendon reflex. You put your thumb over there and you actually hit your own thumb, and you should get a jerk on their lower left arm. It's hard to show you, but you would actually cradle their arm so that they're not holding it and that they're loose so that you get a good response. And then the next is the brachioradialis, which you would hit here on the wrist, and you would get a jerk there. When you do your testing for your reflexes, your deep tendon reflexes, you want to do both the biceps together, both the triceps together, both the brachioradialis together, so that you're comparing side to side as you go through. The next would be the knee jerk, and this would be in here. And you would hopefully get a response where they would kick out. But if you don't, that's okay. Just show me that you have the right area right below the patella here on the knee. And then you would do the ankle, which you would cradle their ankle again, and right back where the top of the shoe would be, you would get a jerk there. And then you would do the Bushinski. And to do the Bushinski, you start here at the back of the heel, and you want to go up on the outside of the heel and across the toe pads. The normal response is on an adult is that they bring their toes together and they point downwards for a Bushinski response. If they were to fan out and the great toe stick way out on the side, that would be fanning, and that would be abnormal. That's normal in children up to a certain age, but then they develop the adult response, which is the downward toeing response. So the next thing we're going to do, and I would say at this point that all his DTRs, including his Bushinski, are intact. And when I talk about DTRs, I talk about the biceps being testing for the C5 and 6, the triceps testing for the C7 nerve root, the brachioradialis is the C6, the quadricep or the knee jerk is L4, ankle jerk is S1, and the Bushinski reflex tests part of the sacral nerve root as well. So the very next thing we're going to have Mr. Bushinski do is I'm going to have him get up, and I'm going to ambulate him to test for his gait. So if you could stand up, Mr. Bushinski, I'm going to have you take 5 steps forward. You're flat on your feet, turn around and come back on your heels. Okay, and then I would have you turn around and walk 5 steps on your toes. Okay, and turn around and then come back and do heel to toe on a straight line. Kind of like what you would do on the side of the road if you were pulled over of suspected impairment. Okay, great. So his station, his ability to stand up and maintain his balance, that is his station, that's intact. His gait, all parts of his gait are intact without any problems. So we're going to go back at this point, and we're going to pick up with the rest of the physical examination. So the next part we're going to do is we're going to do the HENT, which is the head, eyes, ears, nose, and throat. So the very first thing I'm going to do is I'm going to look at the shape and the contour of Mr. Bushinski's head. I'm going to gently palpate it. I don't see any lesions or any abnormal shape, size. The plates of the head, the cranial plates are all intact and they're all fused. There's no scars or any kind of history of trauma or injury. He has some male pattern baldness that's going on, and that's normal for a male. That's his age that would be going on. The next thing that I would do is I would check his eyes. And so I'm going to pretend, because I don't have one, that this is my flashlight. And so with my pen light, I would come in from the side and I would reflect my light on his left eye and look for a brisk response. And then I would do the same thing with the right eye and look for a response. That is called direct consensual, light testing. For pupillary response. The consensual is I would put my hand in the middle and I would come in from the right, and when I shine my light on his left pupil, it would constrict but the right would also constrict. They work in tandem. One should not do what the other one is not doing. So they should completely do the same thing, even though the light isn't directly on the right eye. It should do what the left eye is doing. And then I would switch hands and do the same with the right pupil and note their response and look at the left side and see that it is doing what the right side is doing. I would also probably want to, at this point, note the size of his pupils under the normal light in this room. And his pupils basically are 3 millimeters, and his response for his pupils, his perla was brisk. So perla is pupils that are round, equal, reactive to light, and then the A of perla is accommodation. So with accommodation, again, I would take my pretend pen light, and I would hold it about 8 millimeters or 8 centimeters, away from his nose, and I would ask him to follow my pen light inward, and I'm looking for downward, inward movement of the eyes towards the nose, and that's accommodation, the A of the perla. So the next thing I want to do is look at his nose. So I'm looking for the mucous membranes inside, that they're pink and moist. You can use a nasal speculum, but you don't have to use a nasal speculum. Personally, I don't like using speculums or tongue depressors and things when I don't have to. And basically, I'm looking at his nose and I see no nasal flaring. That's one of the signs of respiratory distress, and I don't see that. Then I would move down to his mouth, and I'm assessing for any circumoral cyanosis, which would be bluing or cyanosis around his lips, and I don't see anything. I'm looking at the general lips, have him open his mouth, look at his mucous membranes, they're pink and they're moist, and there is no cyanosis of his mouth as well. And so I would next look for the presence or the absence of pursed lip breathing. That is another sign of respiratory distress. Mr. Bushinski is not having any respiratory distress. There is no pursed lip breathing. Then the next thing I want to do is I would state that there's no circumoral cyanosis. The mucous membranes of the mouth are pink and moist, and there is no pursed lip breathing noted. I would assess his neck, and so I would look at his neck on both sides to look for any enlargement of the jugular veins, which would be jugular vein distension, and I don't see any. And then finally, we've already tested his muscle strength, and I tested his accessory muscle, his trapezius muscle strength. But the other thing that with people that are having respiratory distress will often have excessive accessory muscle use, meaning they use their sternocleidomastoid muscles and the muscles within their neck in order to effort and get more oxygen in and suck air from the air in the room or the environment. And he's not doing that. So again, he's not in any respiratory distress or having any abnormalities. So I would say I see no accessory muscle use. I see no jugular vein distension. So the next thing I want to do is I want to palpate his carotid arteries on both sides. I would always do one at a time and not both together. And I would use my fingertips to do that, and it's nice and strong. And then I would test the other side, and again, it's nice and strong. And so I would say that I've palpated the carotid arteries and I feel no thrills. The next thing I want to do is I want to auscultate his carotid arteries using my stethoscope, and I would use the bell of my stethoscope for this. And I would do, again, one side at a time and ask him to hold his breath while I'm doing it. That way I don't hear any respiratory sounds imposed on what's going on in the upper carotids. Hold your breath. Okay, breathe, and hold your breath. Again, and breathe. And so I would get all done and I would say I do not auscultate any carotid bruits. So the next thing I want to do is I want to inspect the contour and the shape of his chest. So he has a normal contour and shape of his chest. I don't see any evidence of a barrel-shaped chest. I don't see any pectus cavitum or pectus carnivitum, which is the pigeoning out of the chest or the sunken in chest that would be abnormal. I don't see any scars other than this scar up on his shoulder, and I happen to know from his medical history this is from a rupture of his muscle that was repaired, but other than that I don't see any scars. And so the next thing I would note is his effort of breathing. Again, he's not short of breath. I don't see any abnormal heaving of the lungs or any extra work of the lungs. and I don't see any intercostal or substernal retraction. So intercostals are the spaces in between the ribs, and people that are having respiratory distress will suck air in, and they actually will have sunken intercostal or intercostal retractions. If they're in severe respiratory distress, their sternum will sink in, where they're really sucking air in, trying to get extra oxygen, and he does not have that either. So I would say I see no visual abnormalities in shape, no barrel chest, no signs of scoliosis, no pectus carnivum, no pectus excavatum. I see no visual shortness of breath, no intercostal retractions, and the last thing is patient tripoding. So patient tripoding is when they sit on the edge of your exam table, they lean forward, usually hands on their upper thighs, and they are doing pursed lip breathing at the same time, and they're trying to get extra air in by concaving their back in a concave shape over to try to help assist with respirations. And I don't see any tripoding. So I would say that I don't observe any patient tripoding. The next thing I would do is I would palpate the anterior and posterior of his chest wall with this portion of my hand. And again, I would do 6 positions, 4 positions on the front, here, 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 and here. And I do a clockwise motion so that I don't forget any position. And then I would turn to his back, and I'm going to angle him a little bit. And I would do 6 positions here. And again, just feeling for any abnormal vibrations or respiratory sounds using the palm of my hand. So when I get all done, I would say I do not palpate any abnormal lung vibrations on either the anterior or the posterior lung fields. The next thing I would do is use my stethoscope to auscultate his lungs. And again, I would use 6 positions over the anterior wall and 8 positions over the posterior wall to auscultate. People that are, have wheezes with asthma or COPD often have them up in the upper apices. So you want to start up there. You want to use the diaphragm of your stethoscope, and you want to listen up in here. And again, you're going to do 6 positions in this kind of a motion. And you want to get over here the bottom lobes of the lung. And then you're going to come around to the back, and you're going to do 8 positions on the back. And you would ask your patient to take a deep breath in and out. And I'm not going to make my husband go through that because he'll be real short of breath when he gets done. But on your patients, you would do 8 positions of the lungs, here and here. And the one last thing that you're going to do is the lateral under the axilla, and basically about 3 positions here. On the left side, it's not as important because there's only 2 lobes of the lung on the left side, but on the right side, you want to do 3 positions to make sure you get the right upper, the right middle lobe, and then the posterior right lung lobe. So I get all done, and I would say that I do not auscultate any abnormal lung sounds. His lungs are clear bilaterally, A and P. I don't hear any crackles, I don't hear any wheezes, I don't hear any rhonchi. So then we're going to move to the cardiovascular examination, and the very first step of that is inspection, as well as it is with most of our body systems. And I don't see, and it would probably be better if I had him laying down on the exam table, but I'm not going to do that for the purposes of this demonstration. But you're looking for any abnormal heaving or movement of the chest wall over the cardiac silhouette, which is right here basically of his chest. You're looking for the lung, the ventricles and the atria to be actually heaving and working extra hard to move blood through the heart and out to the body. And we don't see any of that. So I don't see any abnormal heaving or movement over the valvular areas of the heart. The next is I'm going to palpate the anterior chest wall of the heart, and I would do the valvular area. So I'm going to have him put his arms down straight, and this is his clavicle. Right here is his midclavicular areas of both clavicles. So I would come down here, 2 intercostal spaces, and right here I would be over the aortic valve, and that would be the first area that I would palpate with my fingers. And then I would move directly laterally across the chest wall to the left midclavicular line, 2 intercostal spaces down, and I'm over the pulmonic area of the the pulmonic valvular area, and again, I don't feel any abnormal vibrations or movements there. I would drop down about 2 more intercostal spaces to Erb's point. This is where S2 is normally heard the best. I don't feel any abnormal vibrations there. I would come over to here, and I am now at the tricuspid valve, and I don't feel any abnormal vibrations. And then right under the left nipple would be the mitral valve. And again, I don't feel any abnormal vibrations over the mitral valve. This is also where the PMI is located, under the left midclavicular line, under the left nipple, approximately the left 5th intercostal space. And you would get your apical pulse here as well, and his apical pulse is nice, regular, and strong. So the next thing I would do is I would auscultate his anterior chest wall over the valvular areas, the same areas that we just discussed. So I would use normally my bell and my diaphragm, and I would do it with my patient in the sitting and lying positions, because I could hear different sounds with those different positions, but I'm not going to do that for this demonstration. I'm going to actually have him do in the semi-sitting position that he's comfortable in. But again, I'm going to find my midclavicular line, 2 intercostal spaces down. I'm going to use my diaphragm for this demonstration, but like I said, normally I would use a bell and the diaphragm. And if I had difficulty hearing any sounds, either because of the size of his chest wall or just because I'm having difficulty hearing sounds, I could put him on his left side in the left lateral decubitus position, and that sometimes helps with hearing sounds. With women who have excessive breast tissue or adipose tissue, it's often difficult to hear over the breast areas, and putting them in the left lateral decubitus position also helps with that as well. So I would listen here, and then I would move over to the left midclavicular line, 2nd intercostal space. I am over the pulmonic valve, and I hear normal sounds. I would drop down to Erb's point, and I hear normal S1, S2, and this is where we hear S2 the best. I would drop down to the tricuspid valvular area, and again, I hear normal S1, S2, and then finally over to the mitral area, and I hear normal S1, S2. I don't hear any gallops, rubs, S3 or S4 sounds. I hear normal S1, S2. So the next thing I want to do, and those are the normal heart sounds, normal S1, S2. So the next thing I want to do, and I did not hear any murmurs either when I was listening to his heart sound. And a murmur would sound like a shh, 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 kind of blowing, airy sound if you were to hear that. The next thing I want to do is I want to check his capillary refill. So I'm going to take both hands, and I'm going to press down on his nail beds for 2 to 3 seconds and then let up. And I would look for the blood to return in both fingertips. If it's 2 seconds or less, that's considered to be brisk and normal. If it's greater than 2 seconds or more, it's considered to be sluggish. He has nice capillary refill bilaterally, and I don't see any abnormalities. The next thing I want to do is to check for peripheral edema. So I would come up here in his upper arms, then his lower arms bilaterally, try to indent with a little bit of resistance against his arm space, and it comes back up to the normal surface without any lasting indentations or blanching. And then I would do the same thing on his feet bilaterally, looking for edema, and again, it would be normal. He doesn't have any edema in his lower extremities. So the next thing that I would do would be to palpate the rest of his pulses. I've already done the carotids, I've already done the apical pulse or the PMI. So the next thing I would do would be his biceps, and this is in the bicipital groove above the antecubital fossa, above the elbow area, and he's got strong bicep pulses bilaterally. I would drop down and check his radial pulses bilaterally, and they are equal and they are regular. And then I would do behind his right and left knee, and again, it's hard to see on this video, but I'm checking his popliteal pulses, And then I would go down and I would check his DP and his PT pulses on his feet to see, comparing left and right to see if they are symmetrical and equal quality and strength, and they are a 3 out of a 1 to 5 scale. I didn't mention femorals. You don't have to demonstrate femorals in your video, but you would also want to check your femoral pulses on your patients. So the next thing I'm going to check is I'm going to check the warmth of his temperature of his extremities. I've already touched his arms extensively, but you use the back of your hands to feel for any coolness or any change in temperature, and you would do his lower extremities the same way, using the back of your hands to feel for any change of temperature. So he has good warmth and skin temperature without any abnormalities. They're not cool to touch or anything like that. And I don't notice any cyanosis, which would be an indicator that there might be a change in vascularization to those areas as well. So the next thing we're going to do is we're going to move to his favorite part, which is the abdomen. He gets to lay back at this point. So we're going to assess his abdomen. So with the abdomen, the very first thing we do is we look at the abdomen and we look for any abnormal bowel sounds or working of the gastric region, and I don't see anything. We look at the contour and the shape of the abdomen. We look for any abnormal venous patterns around the umbilicus. We look for any scars. He doesn't have any scars. We look for any bruising or any other abnormalities, and I don't see anything. With the abdomen, the next step, and this is different than every other system, is auscultation, because we don't want to palpate the belly and rile up those bowel sounds. We want to assess them in their normal state without pressing on the belly. So we're going to use the diaphragm of your stethoscope, and I like to start on the right side and right upper quad to left upper quad to left lower quad to right lower quad. But if you had a patient that was in for a belly complaint, you would start at the side and the quadrant as far away from the problemed area as possible, and then work your way to the problem area. So I start at the right upper quadrant, and normally you listen to bowel sounds for up to 3 minutes before you determine if they're normal active or not. And he has normal active bowel sounds. Now, your hospitalized patients, you know that we have ileosis, which means the bowels stop moving and working. And so you have to listen up to 3 minutes to determine that there is really an absence of bowel sounds. You use the term normal active for normal active bowel sounds like my husband's. You use the term hyperactive for hyperactive bowel sounds, and you use the term hypoactive or absent for either low bowel sounds, low in action, or absent bowel sounds, they would be absent. The next thing I'm going to do is I'm going to look at his arteries of his abdomen. So his aortic artery should be about 3 centimeters up for the umbilicus, right in about in here. Again, you would use your belt and your diaphragm in order to hear these sounds. I'm going to just use my diaphragm for this. And I don't hear any bruise, no shh, 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 or any blowing or abnormality. I don't see any abnormality in pulsations around this area either. The kidneys are on each side on the flank area of the body, so the renal arteries are just down a little bit and to the side. And again, you're listening for any bruise or abnormal blood flow or turbulence, and I don't hear any. The iliacs are down another 2 to 3 centimeters. These are the iliac arteries. And again, I don't hear any abnormalities. And then we don't do it for this demonstration, but the femorals would be down in the femoral area on each side. And again, we would listen. So we would get all done, and what we would say is that basically the abdomen is concave. I don't see any visible scars. It's slightly obese. It's soft. There's no distension. I don't see any heaves or abnormal vibrations. I don't see excessive bowel movements or activity across the abdomen. I don't see any bruise, no prominent venous patterns, no engorgement of veins around the umbilicus at all. I've listened and I hear normal active bowel sounds in all 4 quadrants of the abdomen. I don't hear any abnormalities. I listen to the arteries of the abdomen, the aorta, the renals, the iliacs, and the femorals. And again, I didn't hear any bruise or any abnormal turbulence in those arteries over those areas. And the next is palpation of the abdomen. So basically, when you palpate, you want to do a soft roll with your fingers like this. I don't believe in doing deep palpation, particularly if they're there for a bowel complaint, because they're going to jump off your table. So basically, and a lot of women in particular, as they get older, have very tender bellies. And so I don't do a lot of pressing on bellies, because even a normal, healthy patient may have some tenderness over their bellies. So basically, I just do a normal roll over all 4 quadrants. And again, what I'm looking for is, do I see any ascites, which would be fluid collection in the belly, which I don't. I could actually do a roll, and if you did have ascites, I would see a ripple wave go across the abdomen, which I don't see. But when I'm doing normal palpation of all 4 quadrants, again, I don't feel any masses, I don't feel any abnormalities, any lumps, anything that is abnormal shape or movement or any kind of area that is tender. He's not indicated that there's any tenderness in those areas. So when I get done, I would say I do not palpate any areas of the abdomen that are tender, distended, or any masses noted with my palpation. And the very last thing is percussion of the abdomen. So when we percuss, we do a tapping motion. You can use 1 or 2 fingers, and you actually take your other hand and tap over the distal joints of your fingers. And you got to practice this so that you get good sound. And again, I start in my right upper quadrant and move down across the belly. And what I'm listening for is the intonation of that hollowness sound. Now, I'm going to hear real hollow sounds over the left upper quadrant, left lower quadrant, and right lower quadrant of the belly. But up here, I'm competing with the liver, which is a more solid organ underneath there. So I'm going to hear a little bit of difference in the sound there, as opposed to over the abdomen. And over the true stomach, you will actually hear a very hollow sound. That's the gastric bubble. You can see the gastric bubble on x-ray. That's the air that stays in the stomach and keeps it somewhat dilated at all times. So with my percussion, I don't hear any change in intonation. I hear normal intonation in all 4 quadrants of his abdomen with percussion. And with that said, that ends our assessment of Mr. Bushinski today. He is a healthy male, and I don't feel any abnormal findings with my assessment. Thank you.